Oh, so we're good to go. Okay. Well, hey everyone. Thank you so much for joining, and welcome to the third of the DHI Enlightened Roundtable. Today, we're gonna be discussing the latest mental health innovations. But first, very quickly, I'll make an introduction before we get started. First, I'd like to introduce the sponsors. And the roundtable is organized by DHI, which is a health tech newsletter that delivers weekly insights on the industry. So if you are not subscribed, I think the link is somewhere on the chat. I would advise you to do so. And also Lightit, which is a healthcare software development and consultancy agency that creates custom web and mobile apps for healthcare companies and startups as well. Today, we'll start discussing the context of mental health very briefly. Then we'll jump into mental health innovation. And lastly, we'll have a few minutes for Q&As. So if you have any questions, please, you can write it down on the chat. We will address them at the end of the roundtable. Okay, let's start with our presentations. I'm Alan. I like to describe myself as a health innovator. I'm the founder and CEO at Lightit. I'm also co-founder of Puppeteer together with Federico, and I'm also an investor in the health tech space. Solome, would you like to continue? Please make sure you mention the company you work at and what's your role there and what do you do? What does your company do?
Oh, yes, which my parents still ask me this every day, but let's see if I can hone in on my elevator pitch with you all. Hi, everyone. I'm Solome Tibebu. I'm the founder and host of Behavioral Health Tech, the largest community focused on expanding access to mental health and substance use care through technology, health equity, and innovation. And one of the major ways that we do that is through our Behavioral Health Tech Conference, which just a few weeks ago, I was so excited to see many of you there. So thank you, and Lightit for the support of that as well.
Thank you for being here. Would you like to continue?
I can go ahead.
Okay.
Hi, I'm Dr. Sarah Oreck. I'm a reproductive psychiatrist by training, and I think after a lot of frustration in private practice with lack of accessibility to specialized maternal mental health care, I started Mavita Health. I'm the co-founder and CEO, and we provide wraparound maternal mental health for the whole sort of stage of parenthood, from trying to conceive all the way through postpartum. And that includes psychiatric care, as well as therapy, individual group therapy, couples therapy, as well as some content and community offerings. We just launched in September, and we're really excited about our traction.
Awesome. Federico?
Yeah, sorry you got cut off for a second there. So yeah, I'm Federico. I co-founded Puppeteer alongside Alan. We build conversational AI agents for healthcare companies that can be used for anything from replacing patient intake forms to providing ongoing companionship and coaching to patients while they're receiving some kind of therapy, to building mental health therapy augmentations to layer in between sessions with actual therapists. Yeah, that's what we've been working on. By trade, I'm a software engineer. I've been working on AI and on some other interesting technologies for a while. I was formerly at Facebook, now Meta, for the last 4 years.
Awesome. Okay.
Hello, everyone. My name is Jose Muñoz, or Jose Aycart, have two last names, originally from Spain. My academic background comes from astrophysics, and my personal emphasis is positive impact, always trying to bring technologies to any space that requires disruption to happen for a positive impact to be able to be opened up as an opportunity. And for the past 3 years, I've been working within the healthcare space at increasing accessibility to new forms of mental health treatments, trying to innovate the psychiatric, psychological, and overall emphasis in the psychedelic space for people to be able to transform the way that their mental health currently gets treated. Very happy to be here today.
Thank you for coming. Awesome. Let's get started then. The first question is for Sarah. Research suggests that the perception and conception of mental health, and more specifically psychiatry, has undergone significant changes in the past few years. What factors do you think have contributed to this evolution?
Yeah, I mean, when I was in medical school and I fell in love with psychiatry, some people said, "Are you sure you want to do that? It's kind of like being an infectious disease doctor in the 50s before there were antimicrobials." And so, you know, is that a good place to go down? Like, we don't know very much about it. Literally, it's like as if we didn't have antibiotics. So, but I did, and I've been really excited to see what has happened in the last few years in terms of innovation. But really, when I was in training, a lot of it felt kind of static. And I think some of it has been, we've obviously done some more research on the brain and are just starting to understand it. But it's really fascinating how far we still have to go, you know, compared to our understanding of the heart, for example. You know, we could describe exactly what it does, how it works. There's been such extreme and incredible innovation in all of those areas, but I do think brain is the next frontier and people are really excited about it. So even when I've been in training, more and more people were interested in psychiatry than they had been for like 50 years. It had been I think a specialty that was kind of abandoned. And it's been really great to see, because of psychedelics, because of other other technologies, including TMS, transcranial magnetic stimulation, just to see a lot of innovation. And even in women's mental health, which is a very, I think, new field that has had some innovation, especially with a new medication that's come out called zuranolone. That's really exciting, that maybe we'll talk about later. But it really is, I think, the most innovation that I've seen through my career, and it's really exciting to see what comes next.
It seems like it's a very exciting time to be a psychiatrist.
It is. I have to think also, you know, COVID catapulting telehealth has really been incredibly impactful. You know, I had used telehealth before because it's incredibly supportive to people that are pregnant and don't want to go into an appointment or had just had a baby. All of my colleagues were like, wait, how do you do telehealth? I need to understand. But I really think it's been something that we've had in the arsenal, and it can increase accessibility so much. And I'm so excited to now sort of be in this mix of digital health, because I really think it's what's going to change things.
And Solome, what would you describe as the current state of mental health awareness and acceptance in our society?
Well, of course, on that same thread of how much the pandemic has accelerated telehealth and teletherapy in particular, of course, mental health conversation and awareness has also expanded. The next generation is talking about mental health, and in that regard, stigma has reduced a bit. But I still think, and this is also going off of what Dr. Oreck had just said around understanding around brain health and mental health in general, just there's still so many questions that I think there's still quite a bit of stigma, unfortunately. Certainly the mild and moderate anxiety and depression is where I think a lot of the stigma has let up a bit these last few years, but substance use, severe mental illness, I still think there's a ton of stigma, unfortunately, and that is going to be a barrier for companies who invest in mental health solutions for their employees. At the end of the day, the employees still need to raise their hand and say, hey, I need help. And so I still think that's a major challenge for all of us as an industry.
Yeah. And I know that because of your background, you have a lot of experience with youth mental health. So can you share any examples or solutions that in your experience helped with this particular segment raise awareness and acceptance?
Mm-hmm. Yes, I, like, for so many reasons, have so much hope for this next generation, so many solutions that are even far and away advanced from what we're talking about developing now are going to come out of the innovations that they bring forth, and already they are spearheading the reduction in stigma. But the reality is we are in a youth mental health crisis. Even our Surgeon General has talked about that all year long. Being an adolescent today is so extremely challenging. I can't even imagine going back and redoing middle school right now, for example. And then at the same time, the shortage of specialists for peds and adolescent mental health is even more dire than overall. So we really have a big problem here. But here again lies an opportunity with technology. This generation is ready and willing and even expects digital to be part of the toolbox to support them in their mental health. And so it's been exciting to see a lot of youth mental health companies develop tailored solutions just for them, which I think is very critical. We can't just expect an adult solution to be retrofitted for the needs of young people. They have very high expectations for user experience, and it just really needs to be a net new product just for them. And so I've been excited to see different companies that have stepped up to the plate to fulfill those needs. For example, like there's one company that has served over 3 million students by providing a school-based solution. How great to meet the teens right where they are. There's other startups in the youth mental health space that have combined digital consumer designers and engineers together with healthcare veterans to be able to create that product that, again, needs to be at that high level of user experience for teens, but also the understanding of effective evidence-based clinical protocols right baked into the apps. And so I'm just very optimistic that we'll continue to innovate for tailored solutions for this community.
Yeah, so one of the problems is the shortage with mental health practitioners and providers. But there's some populations that encounter even higher hurdles when it comes to accessing mental health care. What specific populations and communities are facing more barriers when it comes to accessing mental health?
Mm-hmm. Yes. So my parents are first-gen immigrants to the United States, and it took me several provider meetings, maybe 4 different therapists, until I finally got the correct diagnosis of obsessive compulsive disorder and panic attacks. And my parents' reaction was they didn't even have a vocabulary for OCD, and just huge amounts of increased stigma for populations of colors, immigrants. There's just so much opportunity there for awareness and of not only the types of technologies that we're talking about here that are at the forefront of a lot of the conferences that we go to or organize, but opportunity to go into said communities and understand what has been working for them, what is custom built for them, by them, and how can we integrate those practices into mainstream apps and technologies. So I'm very excited and passionate about that as well. And seniors, I'll throw out seniors too. We talk for as much as we talk about youth mental health, a lot of opportunities for senior mental health too.
Yep.
I would love to highlight something that Sarah mentioned before that I think supports what Solomon just mentioned, which is the aspect of accessibility and telemedicine. One of the statistics that for me just completely breaks my heart to hear every time is that 75% of US counties don't have a mental health prescriber. 75%. And I think that conglomerates absolutely everybody at that high percentage. And so I think it's very important to note that telemedicine is just one of the many, but there's a lot of work that we need to do in order for this form of access to happen.
Yeah. And Sarah, with Mabida, you built a telehealth platform in this space. And I know you put a lot of
with Lighted's help, of course.
Yeah, that's right. And I know you put a lot of focus into health equity, which is a huge challenge. Can you tell us how you tackled this problem, or which technologies, treatments, tools helped you get where you are today?
Well, we're still tackling it, to be quite frank. With our budget at first, we were only able to build for iOS and for Apple products, but we realized that more and more people have Android products, especially when there's sort of a breakdown socioeconomically. So really trying to figure out, well, is this better on mobile? Do people have more access to a smartphone than a computer or a laptop? And our answer was clearly a smartphone is certainly more accessible. So that's something that was very important to us. We're also really passionate exactly about what Jose was just saying. Most counties, like I'm in Los Angeles, but here in the desert, there are barely any prescribers or specialized providers. And how can we get to those communities is really important to us. But then there's more sort of systemic issues, right? Is the Wi-Fi, is there going to be reception? Do people have the ability to get that internet access? And I think that's essential. That's obviously increasing, but we're really excited about sort of tackling all of those issues. And so our initial design was, let's do this as a mobile app, and our Android app is coming very soon. So we're excited about that, but we already started to encounter our patients saying, I don't have an iPhone, so how can I do this? And we actually started sending old iPhones to our patients so they could use the app. But it's certainly an interesting challenge, and we're excited to tackle it.
Awesome. Also, now that we are talking about technology, let's dive deeper into the innovation space, which is the main topic for this roundtable. And the first question is for Federico. Can you share what are some of the strongest trends that are coming in this space of health tech, mental health, that are changing the game for patients and providers?
Sure, great question. So for me, within my area of expertise and my focus, what I've been really seeing is all the massive trends and changes that have been in the AI space, right? And I think the first thing to keep in mind here is that we're still incredibly early. Like it's really only been maybe 1 or 2 years since the underlying technologies that are about to like cause a real revolution in this to exist. It's only been since the advent of large language models that are actually sophisticated and can hold sort of human-like conversations that we could really have like the substrate that we need to build this sort of experiences with AI that can really change the game here. And those sorts of experiences really are going to come down to being able to provide AI mental health coaches, AI therapy, AI ongoing at-home care, support after a doctor has prescribed a patient with a particular protocol and set of medication and set of diet plans and exercises. What we're going to start to see, I think, is this kind of conversational agents, which now are still, not quite ready for prime time. They're going to become, first of all, voice-based, very accessible, very conversational. They're going to become charismatic. They're going to be able to build a rapport with the users. They're going to be something that users really enjoy talking to, and do that over longer and longer, spans of time, in the sense of over days and weeks and months, rather than through a single conversation. And what we're seeing now is tooling being developed to enable sort of the design of these conversations to follow specific guidelines and patterns, right? So when it comes to AI therapy, for example, I don't think we're ready quite yet to actually replace a real human therapist, but it's nonetheless a fact that for most people that are doing therapy, their interaction with the therapist is limited to maybe a bigger 1-hour session once a week, and then some sporadic check-ins in the middle. Maybe during a particularly complicated time, they might have like an impromptu session, with scheduled of an hour. But for the most part, it's this sort of reactive approach that happens on a weekly basis. And the very interesting thing with AI is that you are going to be able to really fill in those gaps and have some kind of 24/7 support that patients are going to be able to to access, they're gonna, as these models and this infrastructure gets better and better, be able to provide sophisticated actual therapy of different, with different frameworks. Is gonna make it easy from the equity standpoint for people that weren't able to access high quality therapy before, to at least start to get some access to it, and be able to leverage all of that for their own well-being. And that's just a sort of first order effects. I think in terms of nth order effects of that, it's really hard to look that far ahead, but it's quite easy to see that the way that we do therapy in itself is going to change when you now have the capacity to design a therapy that is with the user 24/7, right? Which means that instead of being reactive, like, I think the lines are going to start to blur a little bit between being a space to talk and follow a particular therapy framework, but also to do some active life coaching on a day-to-day basis, organizing people's routines, nudging them on the right direction at the right times, intervening at particular moments of their lives. I think that's all kind of the kind of thing that's going to start to flourish. And I don't really know where it's going to end up on, but that's where I've really been, I just think things are going to change faster than all of us are expecting.
Yeah, so it seems like at the moment you can get a unprecedented amount of value when you combine these more technological approaches with the other traditional ones. And the cool thing about technology is that it does not only open new roads for diagnosis and treatments, but it also enhances things like accessibility, affordability, and even the stigmatization of mental health services. And I believe that the most emerging technologies like generative AI, virtual reality, augmented reality, but also the other types of not so emerging technologies like mobile and web apps are on the frontier of this space. So let's dive deeper into the importance of innovation to accompany the evolving challenges in the mental health care field. And also another question for Federico. The way we're taking care of mental health has changed. In the past, people mostly relied on talking to a therapist during therapy sessions exclusively. But now with technology, we can, it has opened new ways to make mental health better. There are things like telemedicine, mindfulness apps, AI coaches. So can you explain more about these new modern approaches and what we can expect in the future, and how these technologies are going to make or are making mental health treatments better?
Yeah, I think it touches a lot of what I mentioned just now. I think one more thing to dive deeper on is, there's, again, within the same space, there's the therapy component. There's AI companions that can be used for things that are more related to, they're not actually prescribing or doing any sort of treatment themselves, but they're more about guiding the user throughout a treatment that a doctor might have prescribed. So as an example, the doctors really struggle with having patients actually adhere to all the protocols that they've given to their patients, especially over longer periods of time. And this kind of approach that I was talking before, I think, can be really helpful with that as well. When it comes to mindfulness, because you mentioned that as well, there's another, I always, again, my mind always is drawn to the more frontier kind of things. We've seen for a while, meditation apps, mindfulness apps, that's been around. We've all tried Headspace. It's awesome. But I think what's been was starting to become clearer and clearer in the literature and in studies that have been done in the last few years is that actual, experienced meditators that have thousands or tens of thousands of hours of meditative experience, we see that they have sort of really measurable and trackable changes on their brain patterns and brain structures that map onto actual changes in their well-being and just base
and vital signs.
Yeah. And that kind of deep changes, those kinds of deep changes they're tricky to get to if you can meditate on a sort of like casual basis, 10 minutes a day to lower anxiety and whatnot. But what we are starting to see as well, which is very much a new area, but I'm very excited about as well, are again some companies that are starting to mix AI with this. So they've done things such as using some sort of brain monitoring devices to map particular brain states to particular meditative experiences. And as meditation sessions go along, they sort of can give you some kind of feedback of like where and how you're meditating and sort of tips to get your mind state into a particular state. So it's kind of like if you're in a dark room and you're blindfolded or something, and somebody's yelling out warmer, closer, you get those kind of signposts as you're meditating. And studies have been finding these experience or these kind of techniques are getting very casual users to meditation absorption states that are quite it's quite shocking how easily they're getting a grip on things that usually take hundreds of hours of practice. So I think that the onboarding ramp for mindfulness and to really have the sort of like full scale of their benefits is another thing that is gonna very quickly be much more widely accessible than before.
And you haven't talked about virtual reality or augmented reality. I know that most of your work at Facebook was at the Oculus team working with VR headsets. And I've also seen some companies in the mental health space using those technologies as well. Have you seen any interesting products using those technologies for this particular space?
Yeah, I mean, my background at Facebook, I was working in VR, not specifically on VR therapies, but we were building feature of work use cases for VR. What I've been definitely following is the literature in this space. There's some use cases for VR that are, unambiguously, like they work. They're very, very effective. The most obvious one is anything that's related to exposure therapy, when users have some particular phobia, let's say fear of heights or fear of spiders. That like putting users in a controlled VR environment where they're actually safe and the environment can be correctly sort of like parameterized to make sure they're not panicking and they're like slowly eating into those experiences. It works. It's crazy. Like the results have just been very, very conclusive, and I think it's starting to be productized as well by some companies. One that comes to mind is Mindco, which is a company that I know the founder of, and they use VR
on the first page of this roundtable.
Yeah, they've used it for exposure therapy. They've used it for smoking cessation. So I think it's another space to explore. It's very interesting to see how malleable our brain becomes when we can actually have like a full control of, to be very geeky about it, the input and output of it. You can like control what is displayed to the user and what they hear. It sort of brings a new sort of neuroplasticity to the brain, and it means that some experiences that on a regular setting might have not stuck, they do stick when you're in VR.
Yeah, very interesting. Sarah, I know you are introducing, or you've introduced an AI note-taking tool to your product or to your workflow. Can you tell us more about that experience and what are the benefits and the limitations? Are patients and providers ready for these innovations?
Yeah, so as a practicing physician, I have to say I'm probably more conservative around the idea that therapy will be replaced in the next 10 years by AI. But I do think that as physician and therapy and sort of provider extenders, AI can be absolutely fantastic. I think there's still too much stigma around mental health care, and you still need the human touch, but I certainly think hybrid approaches can be very helpful. I love the idea of sort of AI to help with adherence and even directions about medications when you're not with the patient. Those are all like ways that AI can be physician extenders. And what we found was like sort of low-hanging fruit are all of these new technologies that basically act once they have a transcript of a session, can really translate that to a very quick note that takes our providers, 10 to 15, maybe sometimes 20 minutes to kind of come up with. And this is something that's been really burdensome to clinicians for a long time. There have been studies that show that physicians at hospitals, for example, spend an inordinate amount of time on EHRs, which were, electronic health records were supposed to make things easier, but in fact, they actually made work harder and more work for physicians. So they have less face-to-face time with patients. And I think all of us that do clinical work, we want more time in front of our patients and with them and caring for them, and less time documenting, less time doing things for billing, for example. But I see AI as fantastic tools to sort of has been working really well for us, for example, to do our note taking. But I have to say, people are hesitant. They worry there's something listening in. Where is this going to go? Where's the privacy? I think we've just had so many examples of data being sold, of a lack of trust in technology, to be quite frank. And these conversations in behavioral health are some of the most vulnerable, intimate conversations that people have. I mean, it's going to your OBGYN can be less intimate than actually what happens in a session with a therapist. So I do think that it comes with a lot of caution. We've been very careful in terms of explaining and being very transparent of exactly what it does, that these are just audio recordings. They get deleted immediately as the transcript is made, and they're not used for any other purpose. But we also have to vet the companies that are doing it and to understand, is all of this safe? And we do as much as we can to make all of the information as anonymous as possible, so no names are mentioned. But it's certainly a challenge. And I think with everything, it's going to be a challenge as we add in all of these tools. I'm excited about them, but I think we have to be cautious.
So people are concerned because, of course, this is a new technology. And they're not so used to interacting with these types of AI assistants and tools, which of course they have their advantages, but also I think there's some disadvantages, right? There's some risks when we apply these new emerging technologies, specifically with AI. How can we ensure that these resources are used in the best, safest possible way?
Who's that question for?
Anyone, you can answer.
I think it's slow. It's a slow uptake and being very thoughtful about how everything is used. But being open to like, this might not work. And if there is a bad outcome, to kind of rethink that. I'm very concerned about AI chatbots, for example, or talking to patients and potentially it going in the wrong direction. And in behavioral health, we have patients that are at very vulnerable states that may have suicidal ideations, for example. And it's hard to replace sort of a human kind of making those interventions. But I think it's learning from mistakes, but also, again, applying these things cautiously.
Yeah, I tend to agree. I mean, it's a scary time, right? Like when it comes to the pace of progress with AI, it gets a bit overwhelming at times. It's hard to have like there's like some event horizon to up until that we can sort of like envision how things will unfold, but we don't really know how things will progress. So there's a real there's going to be real risk along the way when it comes to up until the moments that we can actually sort of foresee progress going to. The first clear risk that I think you mentioned perfectly is the part of the thing that makes AI so interesting is that, and so scalable, is that you're not giving it a predetermined script where you know exactly what it's going to say at every moment, right? you're giving it like layouts of what kind of conversations you can have, and you're giving faces to it, but then inherently it's gonna write its own answers, right? And when it comes to the current AIs, they're very easily primed. It's easy for them to sort of be diverted into a kind of conversation that you didn't mean for your patients to have in the first place, especially when it comes to patients that are suffering from, let's say, if you have a patient that's suffering from clinical depression, and AIs inherently are trending to mirror the user that they're talking to, that you can easily see where that can lead, right? Because you can have a reinforcing negative loop there.
Or psychosis, right? Like for severe mentally ill, that's something that is right when there's already some difficulty with sort of reality. It's really kind of complicated to layer that on.
Yeah, that's definitely true. And let alone just the broader point of, I don't know how comfortable everyone has gotten so far with patients and just people in general spending long parts of the day talking to like non-humans, right? Like to inanimate computers. It's a weird future that we're heading towards. I think part of it just has to be taken in with some equanimity, where we just really have to steer the ship as best as we can while this is happening. And the second is just do it with a lot of responsibility, right? It's easy to see how things can go wrong. You need the right sort of guardrails and safeguards and monitoring to make sure that whatever happens in any AI patient conversation, it doesn't lead to, it doesn't derail into a bad outcome. There needs to be a very simple way for humans to be drawn back into the loop if certain events are detected. And there's a lot that needs to be done with that, and there needs to be auditing and regulation in place for all of that as well. And then, yeah, besides that, I guess we do have to sort of, as a like societally, decide what kind of role we want to give to just AI agents within, like, how much do we want to anthropomorphize something that ultimately is not a human being, right? But that's above my pay grade, guys.
There's an area that I think AI is also very fascinating, that touches the humans, but helps them in becoming better doctors, in becoming better healthcare as an industry as a whole, which is diagnosis. We've briefly touched on it, but when we deal with mental health disorders are incredibly subjective, at least a lot of them, where currently the ways that we have to devise or understand where somebody is falling under and the ways in which psychiatry currently buckets diagnosis are pretty stagnant. And for us to be able to understand that anxiety for one person might be a completely different route of treatment than anxiety for someone else.
Well, and Jose, you'd be horrified to find out a lot of it is just expert opinion. It's actually not based on that, right? It's like 10 white men got together and decided this is what generalized anxiety is because this is what we've seen. So it's not even based on a lot of, significant evidence.
Totally. And it's surveys, JD7, PHQ-9, SAD-10, and you're looking at surveys that when you think of anxiety, you need to look at biometric data, like you were mentioning before, Sarah. You need to look at EEG scans, Federico, like you're suggesting, to see how your brain communicates. We could even go into fMRI depth, but there is also cognitive behavior, sleep quality, exercise. I mean, there's so many things that really wrap around the connection between mind and body that AI could really help in conglomerating millions of data points per patient at some point and really being able to achieve that precision psychiatry, not just into what to do, but how does a patient change with the treatment? And we're incredibly excited to be able to see how we can leverage it to improve patient outcomes.
Yeah. And not all of the innovations are technical. There are also other types of innovations in this field. So now we're gonna dive deeper into other non-technical innovations happening in the mental health field. There are drugs that historically have been scheduled as Schedule 1, such as cannabis, MDMA, LSD. Schedule 1 means that they're super dangerous because they're very addictive and potential, and people are gonna abuse them if they take them, but also that they have no clinical usage at all. And now many of these drugs that have been scheduled in this way suddenly became interesting for research, or even they already found that they have potential or applications for psychiatric treatments. And one of the biggest challenges is breaking the stigmas around these drugs for both patients and providers to prescribe them, or even researchers to start experimenting with them. So, Jose, I believe that what you're doing in WonderMed is very disruptive. What value are these drugs, such as ketamine, which is not on Schedule 1, but still was used just for different purposes, and psychedelics bringing to mental health? And what is the current status of adoption by health professionals?
I could answer this question in many ways. I think to boil it down, I like to separate myself from the conversation of the substances and think more about the way in which we get treated in the first place. I think for the longest time, mental health has been creating a philosophical dependency on the human being, that when I found to be sick or I found to have a disease, there must be something that heals me. There must be a pill, there must be a substance that can take care of me or improve my life. And I think that that creates a dependency that doesn't allow the individual to actually grow out of or change from their current setting. And that's what serotonin thesis, out of which SSRIs and benzodiazepines have been developed, that currently are given in high volumes. 333 million prescriptions happening every year in the US for these two types of substances. Yet mental health keeps going up. Suicide is the second leading cause of death, ages 15 to 34, based on a report by the CDC. And the first reason is undisclosed causes. So things are not improving, yet we keep giving them in the millions. And so if we take that as a science that has been debunked now by scientific literature around it not being a strong causality of serotonin levels, for example, with mental health, mood, or behaviors, we then need to reframe how we're treating this. And psychedelics as a whole market bring the notion that the human is the solution, the same way that the human and the brain is the problem. When you take that into account, you allow the individual to understand how is it that themselves can change. This holistic mentioning that we said before of including, for example, a healthy diet or exercise in conjunction with a change maybe in your profession or the way that you communicate with your family, as crucial elements of you actually changing, are not dependent on a chemical imbalance, are more dependent on how you perceive your reality. And so this aspect of perception to perspective is a transformation that psychedelics bring. You mentioned MDMA, ketamine, psilocybin, LSD, DMT. There's multiple psychedelics that fall under different categories. However, all of them bring this notion of increased neuroplasticity, increased neural connectivity, increased ability of somebody to gain a certain perspective in their life. And what we've been able to notice is that in this case, ketamine, which is a fantastic substance. What I mean fantastic, because it's not controlled by IP. It's been with us for so long in our healthcare industry, where it's the 3rd to 5th most used drug in every hospital across the nation for multiple use cases. It showcases an ability for patients to be able to gain this perspective in a very safe environment and very effectively. Now, ketamine doesn't heal of any form of mental health. Ketamine puts people into a state from which they can realize of an insight that they can work through with their therapist, that they can actually take action into to make that change. You mentioned adoption. There's a lot of stigma, but I think I'm a true believer in data. As a scientist, I believe that science proves itself if it is correct, and it debunks itself if it's not. And so for us, is making sure that we provide with as much data, with as much visibility to the world to observe what's currently happening. And that's what we did, for example, with our patients. And we've partnered with UCLA to push forward a clinical study that supports the idea that there's something here that we must keep on studying. How do we think that we adopt this? I think telemedicine has been massive. A lot of people are hearing probably what I'm saying and thinking, oh yeah, I've seen an ad on ketamine. I've heard about it, or somebody has talked to me about it. 333 million prescriptions don't happen through social media advertisement. And I think the best one to know this is Sarah, because it is true that individuals currently, as clinicians, are the ones that have their hands tied, don't have as many resources, and have a flood of patients coming to them on a daily basis that doesn't really allow for innovation to happen at the speed that we need. So how I think adoption could come is through the actual experts, the vocational culture of clinicians, from MDs to physician assistants to psychiatrists, that are currently allowing patients to get better, for them to get trained, for them to have visibility on the data, for them to get access to resources that actually allows them to prescribe new medicines, and just being very transparent, allowing data to speak for itself.
Thank you.
And I would add to that is that research should include women, and hopefully in the future include pregnant and lactating women, so we can actually use those results. So my field of reproductive psychiatry suffers from having to use all of the old medications because those have the most data and have observational studies, not that many randomized controlled studies in pregnant people. And so especially because studies predominantly are done on males who do not have menstrual cycles, because that's been thought of as, messing up research numbers. It becomes hard to then adapt it to other people in the population, to other races, to other ages. And so I think that's hugely important as well.
Totally. Yeah. I love that she says that. That's why, for example, what we did an observational study, taking into account that we were going to let everybody come in. So you're going to get treated. XYZ is the reason. I'm going to treat you. And regardless of the data, your background, your sex, anything, then we're going to analyze it and try to find the correlations that showcase improvement or not. And you're totally right.
That's great. And ketamine studies have been challenging to actually, when you look at them, because people know when it's placebo versus ketamine, because ketamine has some dissociative effects. So it's been, hard to, and there is a lot of positive, I think, associations with ketamine right now. So a lot of the patients did get better. But it's great to hear that, and randomized controlled trials are fantastic, but they need better blinding, where the placebo is something that also feels dissociative or similar.
That's right.
I have a quick question, Jose. Is your sense from the studies that I've seen some studies showing that doing ketamine therapy while under anesthesia doesn't yield the same effect. So would you say that there's something inherent to the dissociative state that ketamine puts you through that is causing this sort of improvements in the patients? Like, is being conscious? Yeah.
100%.
It is about
I believe, but that's why I also believe that love can change people, that giving birth to someone can change people, that traveling to a different country changes people, that learning a new language, changing your professional career, doing exercise, anything that puts your mind at a different state from which you can gain a perspective to whichever is that you're facing in life is the thing that actually allows you to gain insight. Dreaming, sleeping, eating better. And so, ketamine, it's not the fact that your glutamate neurotransmitter network gets more potent that you actually get better. It's the fact that physiological change allows you to gain a disassociation perspective that then allows you to see things differently. So yes, I couldn't agree more with that.
How do we get the next generation comfortable with something so novel?
They already are comfortable. I think it's a matter of giving them information. I think if anything, it's the older generations that need to feel more comfortable because of the skepticism building around it for generations. It is clear that once you look at the population that has tried it and you ask them about it, I think that's all you need to hear. Rare is the case then you go to a large audience that has tried these new forms of medication and they compare them to the old ones, and they're going to highlight all of the negative aspects of skepticism as opposed to the positive ones that they have seen. And so for young generations, my first approach is always forget the substance, focus in the way of dealing with mental health differently. I don't think that people with 16 years old should be doing psychedelic medicine, not even maybe with 18. I believe that they should be focusing to how to engrave exercise in their life, how to engrave positive thought loops and thinking on their life. The ability of potential, I think, is the core of education, to believe what's possible. And if we change that narrative alone, I think a lot of people are going to automatically start feeding into a different loop of thinking.
Yeah, that's what we were so passionate about bringing MaVita Health to the market, because we found that because of the constraints in our healthcare system, if a person in their postpartum goes to their doctor and says, I think I have depression, or it screens positive for depression, they're just given an SSRI no matter what. And that's not evidence-based care. We understand that obstetricians aren't therapists and they can't provide therapy in a 10-minute session they have with their patient, but they should also be able, or people should be able to access other means by which to get better. And evidence-based care for that population, for example, is all of those support, nutrition, physical exercise, mindfulness, psychotherapy before you ever try any medication. And so that really resonates with me as well. And I do think that there's so many other sort of lifestyle modifications that we talk about, but we associate those with costing a lot of money in this country, right? Good nutrition costs more money than packaged or processed foods. So there are also more systemic issues at play.
Absolutely. Yeah. Psychiatry is becoming more individualized. And one of the things you're doing with Mabida is understanding that postpartum depression is not the same as general depression that male person can have. And you're addressing that with very specific adapted protocols.
Right. Or even that the same person had 10 years ago before they ever had children. It can look very, very different.
Yeah. So why is it that traditional protocols for these conditions are not optimal? And are there any specific new drugs to treat these conditions at or after pregnancy?
Yeah, so I think that the question is kind of what we've been talking about and been hinting at, that women's mental health has not been, or women's health in general just has not been something that we've invested in, even though we're high utilizers of healthcare, maybe certainly more than men in this country. And so it's left us in a situation where we don't know that much about our bodies or what's happening with them. If we had just a little bit of the investment erectile dysfunction had, we'd be in a really great place, but we haven't. So that's a little bit of that. And yes, there was a breakthrough in the medication called zuranolone, which is very, very exciting. That's really an active neurosteroid, so a completely different mechanism, hormonally based, that treats postpartum depression in sort of this way that we've never seen before. 3 days of taking this medication and there's an effect. You only have to take the medication for 2 weeks. The same company actually came out with an infusion a couple of years ago, but it was an IV infusion that required 60 hours. And you need to be supervised. So of course you understand that's very difficult, and the cost was over $30,000. Unfortunately, we've got some challenging news, I think last week or 2 weeks ago, that this treatment is going to cost $16,000. And so I'm not sure how accessible that will be to most people, or if payers will actually want to pay for it, unless someone has failed a bunch of different trials. And, it's going to be a lot of prior authorizations for us, which is, again, more work, and where AI could actually be very, very helpful. Please, AI, do prior authorization so I never have to. But yeah, it's some big challenges there.
And that's one of the main challenges with innovation. It's either very expensive or payers don't cover for it. So maybe, Solome, what tips can you give to health tech founders who may be listening to this roundtable, who are trying to get payer coverage for their innovative solutions to actually get it?
Mm-hmm. Well, I'll answer the question, but related to it, something that has come up throughout the hour is this idea of having the specific communities be involved with the development of the solution, whether that's pregnant women, youth, whomever. That is only going to make the solution more successful ultimately with payer partners. But as a startup founder, co-developing with the payer is also critical. These are long sales cycles, as many of you know, and how tragic to approach a plan or employer with what you think is a fully baked solution, only for them to say XYZ reason, this doesn't make any sense. But if they're right there co-developing with you, they can be more sympathetic. They can offer some feedback like, no, we're not going to do a value-based contract with just 3 pilot patients that you have right now. So developing those relationships early on to build the relationship for contracting eventually is my biggest piece of advice on that front.
Yeah, that's
And
a very good.
accessibility to payers would be phenomenal. Like I think it's unfortunately in the US, payer systems are really like black boxes. You don't know how much they're going to reimburse. They don't print any. There's a lack of transparency, to say the least. And so I think there could be some progress sort of jointly in trying to understand, what do you need from us, and can we understand a little bit about how the system works?
Yeah. So we only have 2 minutes left. It's time for Q&As. We have some questions here.
There's been great comments too. I love
Yeah.
that $16,000 is less than hospitalizations and residential. So fair point. Maybe Sage's pricing is okay.
So I guess you as speakers are able to see the Q&As. So feel free to pick any of those and answer it.
EHRs as a therapist, you tell me. I don't know. There's no perfect solution. I've used a couple, and they all have their challenges. I still haven't met an EHR that I really loved, but maybe it'll come soon.
There's
golden standard. There is one, just because people call it golden standard. In my opinion, it's not gold. It's just a standard. And I think that is what's actively being changed right now in psychiatry. But there are certain surveys, like Sarah mentioned, that some people decided are the way to go, and people have just been using them because past literature was built upon it. But thankfully, there's more and more different tools to be able to measure them that are getting tested and verified on a clinical study basis. So I wouldn't necessarily go for one specifically, because it would be
this is for surveys, or what is your comment, Jose?
The question was in relationship if there's a golden standard for measuring mental health.
No,
yeah.
And they're not measured. The ones that we have are sort of, yes, they have been measured, but all in homogenous populations that don't reflect diverse communities. And sometimes the way these questions are asked, like, don't sort of get the answers you need from different populations, and it's really problematic.
No consensus amongst payers.
Yeah, there's a question for Jose on the chat, not on the Q&A. When do you think that insurers will start covering IV or intramuscular ketamine?
My answer to that is that they don't have to. And let me elaborate on why. When we think of pricing, ketamine is incredibly affordable. And I think most of these medications are as well. The cost is not on the medicine itself. It's on an insurance company as a payer wanting to coverage for the time of the clinicians. The process itself, is it as part of my codes or not? Am I comfortable covering for that treatment or not? Not the medicine. What I mean by that is that happily every doctor would pay for the cost of the ketamine themselves. We're talking about a couple few dollars. The cost comes with all the support that needs to come with it, that insurance companies are already covering. Therapies could be covering a large scale. Clinician consultations are getting covered. Psychiatric evaluations are getting covered. There are ways in which patients are going to start being able to receive this in a much more accessible and affordable way. And we don't need to wait. I think that the private space can get maneuver enough in the space to make things affordable. And obviously, it's a matter of proving its efficacy. Insurance companies want something that they spend less money in. If you have something effective, I spend less money as an insurance. Therefore, I'm going to want it. If my payers get more happy about the offerings that I have, more people are going to pay my insurance. And so I think new innovation in mental health that is effective, it's naturalistically in the path of payers starting to get it covered. We in the private space, and I think this is a responsibility for every single entrepreneur, we need to see how the private world can innovate on pricing. When I hear something in the thousands of dollars, I think it's ridiculous. Of any form of sort of medication, unless there's an actual proof that manufacturing of it is indeed of that cost. Maybe we're getting them out of the moon and I'm not aware of it. But the reality is that we can make it more affordable. And a company like us, for example, we are dividing by 4 the cost of the market. And yes, it's at the cost of margins and at the cost of profits. But I think patients are going to have a need to have the ability of choosing companies that are doing this for the right reasons. And it's already here. It's already getting more and more accessible, and it will get to be so more in the future.
There's a question here for Sarah and another one for Federico. The one for Sarah is to what you just talked about. What is the liability associated with providers suggesting using AI to a patient?
Yeah, as I was actually hearing it, I was thinking, what malpractice insurance is gonna cover this, and who's liable? Especially because in the U.S. there's a lot of, it's very litigious when it comes to medicine, and unfortunately sometimes we practice defensive medicine. So I am not sure, and I think that's a conversation many malpractice insurers have not had or kind of evaluate yet, but that'll be very interesting to understand, because certainly those recommendations could really be damaging if there's a bad outcome for the physician or the practice that suggested them or is using them. So I don't have a good answer for that. Yeah.
As an answer that I do have within my space only, when we work with providers, we provide malpractice insurance. So we are able to achieve through economies of scale and ability to protect.
Oh yeah, no, I just wonder what will happen if there's a bad outcome with AI with the malpractice insurance. If that's, I don't know if that's covered, right? And that again, that sort of the technology is outpacing some of the regulation, and that's challenging for practitioners.
Yeah, and from our side, we, for the most part, haven't almost no providers are looking to do actual direct to patient diagnosing, or it's so far AI is definitely taking on a complementary role, not on the
replacement role, yeah,
not on a replacement role. And it's hard to see exactly where that'll go. I think it's wise to be slow with making regulatory changes for this. This is unproven technology so far that we've started to see the fruits of. I think it'll be a matter of as particular uses of this start to be proven effective and proven safe, the appropriate regulation will follow.
Yeah. We're 4 minutes over time. Let's just pick one last question, and then we'll try to get the speakers to answer them by email, and we'll share them with all of the participants here. So feel free to pick any of the questions if any of you want to answer.
I have to get going, but if you'll send me one, I'll certainly answer it. Okay. Thank you. Okay.
Thank you.
Thank you, everyone, for joining.
Okay, yeah. Well, this is the end. Thank you so much for joining. Thank you especially to the speakers for being a part. This was a great conversation. So see you in the next roundtable.
Thank you so much, everyone.
Thanks, guys. It's been great.
Bye.